Wonderful. So it's a pleasure to be here. And for those in the audience, this is one of our major lectures of the year for the American College of Cardiology in New York State. As you know, we have two governors, myself and Dr. Badula, who is called to emergency right now, so she can't make it. But we're honored to have this 1-hour lecture tonight. And this is a New York Cardiac Center lecture. So we have a lot of lecture series in New York State and a lot of different committees, but this is one of our preeminent ones. This has been around since 1997. And first one, I think, was Milton Packer. And then over the years, you've had really a host of luminaries from Val Fuster to John Lara to so many different people. The list goes on and on. Deepak Bhatt did it last year. And so I think this is an important lecture. And we talked to somebody who just came to New York State. So I want to give him a warm welcome. But before we do that, I do want to introduce Dimitri Feldman, who will be our moderator and host tonight. Dr. Feldman is a professor of medicine at Cornell Medical Center, New York Presbyterian Hospital. He had the dubious experience of being my fellow a long time ago when I was a first year attending or second year attending. So he was an exceptional fellow and went all the way to full professor there. He's director of endovascular services, and he'll also be one of the incoming governors of New York State for downstate, along with Dr. Vijay Iyer, who should be on this call as well, or I think is also on this call. So the two of them will take it away and introduce our guest lecture today, and then they'll also host a moderated session towards the end. Dr. Feldman?
All right. Thank you so much, Dr. Nadeau. And it is truly a pleasure to introduce Dr. Robert Harrington to speak to us tonight about the future of clinical trials. Let me, by way of introduction, just summarize Dr. Harrington's remarkable academic career. His fellowship and early career was at Duke. He was a director of DCRI from 2006 till 2012, where he directed, designed, and executed a number of clinical trials. He was then a chairman of the Department of Medicine at Stanford between 2012 and 2023. And recently, as Dr. Nadeau mentioned, last year, he came to my home institution as a dean of Weill Cornell Medical College, New York Presbyterian Hospital. He served at multiple societal functions, including prior AHA president. He's been a chair of FDA advisory committees on cardiovascular and renal drugs. Multiple awards. I can't summarize all of them, but Master of ACC in 2016. He had a Stokes Medal from Irish Cardiac Society in 2022. His academic career is remarkable for over 750 peer-reviewed publications, where he's focused on antithrombotic strategies in ACS and improving methodology of clinical trials. Since having a career where he had direct impact on execution of multiple clinical trials, resulting in approval of numerous pharmacological agents that we're currently using today, there's no better person to talk to us today about the future of clinical trials and the lessons he's learned over his 30-plus career. Dr. Harrington, it's truly a pleasure to have you tonight.
Dr. Feldman, Dr. Nadeau, thank you for the kind invitation, for the nice welcome to New York. It's really been a fabulous first few months here as I continue to learn my way around Weill Cornell, but by extension, the larger cardiovascular community in New York City and New York State. So I will be a proud member now of the ACC of New York State, and I look forward to coming to future meetings, and I appreciate the invitation to this one. My only regret is that I'm not seeing a lot of my both old friends and hopefully new friends face to face. So we'll try to make the best of this over Zoom, and hopefully we'll have some time. Well, we will have some time for conversation at the end. As Dr. Feldman has said, what I'm going to talk about is the future of clinical trials, and I'm going to use my journey, if you will, from my early days at Duke up to my current days here at Weill Cornell, to kind of lay out for you what I think are some of the key lessons that I've learned as a trialist that I think can inform where we should be going as a community. I'll use a lot of examples from things that I've done for a couple of reasons. One of which is I know those examples best, and the second of which is if I'm going to pick on anybody, I'll pick on work that I've done as opposed to criticizing other people's work. Let me get started here. I think I may have to have you, there we go. Here's my research and consulting relationships. I always pause for a moment here because I do have a lot of relationships with regard to grants and consulting. And I think that's also one of the lessons, that if you're a clinical trialist who is interested in human therapeutics, you're going to work with a lot of different people. And so I work with federal agencies, I work with private industry, I work with foundations, and all of whom have provided support for the kind of work that I do. Well, most broadly speaking, why should we care about this? And I think we should care about this because there's a tremendous need in our society for evidence, and a high quality evidence. We need high quality evidence to practice medicine. Think about the ACCHA guidelines. We need high quality of evidence to understand if we're actually adhering to high quality delivery of care. We need to know that there are studies, including from my former research group at Duke, that support this notion that guidelines-based care can lead to improvements in outcome. From a societal or policy perspective, it depends upon evidence guides regulatory approval, reimbursement strategies. So there's a lot of reasons why we should care about providing evidence. Could you go to the next slide? So Dimitri gave a bit of my background as to why I am interested in this topic and where my journey has taken me over the years. Over the past 33 years, I've been a faculty member at 3 places, at Duke, at Stanford, and now at Weill Cornell. I've also played leadership roles on the national scene that might have informed me along this journey. Here you see some of the things that has informed my perspective on clinical research over the course of these last 33 years. We go to the next one. So the future of clinical trials over the last 30 years, let's start with my early to mid-career at Duke, where I trained, where I joined the clinical practice, where I began my research career in the Duke Databank for cardiovascular disease and moved to the Duke Clinical Research Institute, which was the successor to the Databank. Throughout that journey, I've learned the importance of clinical observation as being fundamental to the basis of research. And the role of trials in providing the evidence that we need to guide both practice and policy. I also learned important lessons about how one puts together multidisciplinary teams. And I've indicated on my conflict and relationship statement the importance of having both industry and federal funding to do this kind of work. Here's the first lesson that I've learned, and that is to listen and to follow leaders who have big visions and who can help us understand what we might want to do. I know that there are some colleagues who have trained at Duke who are perhaps joining this talk tonight, and the Duke family always recognizes the critical contributions of Dr. Eugene Stead, who was the chair of medicine at Duke in the 60s and 70s. Dr. Stead had the visionary notion that's seen on the slide here, that chronic multifactorial disease can be studied, but not by the methods of the present or past. If one wishes to create useful information, computer technology must be exploited. Now, today that makes sense, and you'd say, well, of course, that's what we ought to be doing. But it was really Stead who brought the computer into cardiovascular medicine as a way of aggregating and allowing analysis of information so that the next group of patients could be informed by the treatment of the prior groups of patients. And this seems completely in line with what we do today. But Dr. Stead said this in 1970. This is 50 plus years ago, where he had this notion that what we should be doing. And it's only today that we actually have the tools, and we'll come to that, to actually realize Stead's vision. Could you go to the next one, Katerina? And maybe I'll just have you take control. It seems to be. When I left Duke in 2012, as Dr. Feldman indicated, to go to Stanford, this is a picture that they gave me to symbolize the work that we had done in the databank. In the databank that began in the 1960s, this was the original registry from the Duke CCU, where information was recorded on every patient who came into the Duke Cardiac Care Unit. And then this information about age and demographics and disease of interest was then put into the computer, into a database, so that we could begin to understand the aggregated effect of treatment, the aggregated effect of risk factors on outcomes, et cetera. Could you go to the next one? And from that aggregated data, the early work of the Duke Data Bank was to begin to understand how you could use this large collection of data to draw inference around perhaps some of the treatments and some of the outcomes associated with those treatments. And so Duke fellows who have worked in the cath lab all entered that data into the data bank. And the older fellows will remember that we would actually print out the prognostogram on our patients. And this would give us information on patients like you, so that we could go to the bedside of patients and say, for 100 patients who've had disease just like you, with risk factors and with coronary anatomy, with left ventricular function, this is what your survival would be over the course of 5 years if you, for example, were treated with medicine. Or what was your outcome if you were treated with surgery, with bypass surgery? So this became an enormously informative way to me, or influential way to me, to begin to understand you actually needed to use aggregated data at the point of care, well characterized, well curated, well analyzed, in order to inform clinical decision making. Next. And I put this picture up for a couple of reasons, one of which is just to appreciate that at one point in my career, I actually had hair. This was at the 25th anniversary of the data bank in the early 1990s. And this was the data bank faculty, a lot smaller than what you see today at the Duke Clinical Research Institute. But the real reason I put this up here is that this was the genius of Dr. Stead, and then ultimately of people like Rob Califf, who led the data bank. And that's the multidisciplinary nature of the teams that it took to do this kind of work. So when you look at the picture here, there's clinicians, Rob Califf, myself, Dan Mark, Magnus Oman, Jamie Jollis, Steve Culp. But there's also biostatisticians and data scientists, people like Liz DeLong, people like Frank Harrell, Terry Lee, Doc Mulbauer. These were the way that we really learned how to do work in multidisciplinary teams. And this remains one of the key lessons for me, that work is done most effectively when you bring diverse teams together with differing backgrounds, with differing sets of experiences, with different set of expertise to solve important problems. This may be one of the real geniuses of Rob Califf, of being able to bring all of these individuals together, have us all working in the same building, on the same floor of buildings, to be able to really approach problems from very different perspectives to make progress. Go to the next slide. This was the next big piece that was highly influential to me in the early 1990s as I began my Duke Fellowship to really try to understand the importance. The data bank was non-randomized data, and a lot of the time in the 80s was spent on developing techniques, statistical techniques, by which one could deal with the non-randomized nature of the data in order to be able to gain causal inference. And it was the CAST trial that I think really sent if you will, a shockwave through cardiology and maybe more broadly medicine, to say that the real way to answer questions, yes, observation is important. Yes, carefully done observational analyses can be informative. But if you really want to understand therapeutics, if you really want to understand the concept of A versus B, what you really need was randomization. And I think most of you on the call probably recall this trial and have read about this trial, but let me just review it quickly, that in the late 1980s, it was observed Actually, one of the first papers on this came out in the early 1980s by Rob Califf when he was a medical student, where it was determined that PVCs were frequent in the post-MI period. And we learned, again, a lot from Rob's paper, as well as those from other individuals, that people who had more PVCs had a greater likelihood of dying in the first year after their heart attack than people who had fewer PVCs. The second observation was that there was a group of drugs, antiarrhythmic drugs, which could suppress those arrhythmias. The third observation was that, well, it would make sense then if we could use these drugs to suppress the arrhythmias, then we could save lives. Fortunately, somebody said, it's a great hypothesis. We should do a randomized clinical trials to test that hypothesis. And so a randomized trial was done that compared antiarrhythmic therapy to placebo to suppress PVCs in a group of patients who had excess PVCs in the period after their myocardial infarction. And in fact, there was an important treatment difference here. The problem was that antiarrhythmic therapy increased the risk of dying after a heart attack when compared with placebo. This really went against what the prevailing hypothesis was at the time, but then set us up for this notion that we needed to be really careful because our intuition may not always be correct. Even though we think we understand the biology and we think we understand why drugs work, you really only understand when you expose it to randomization. Next slide. And this was in the period of time that I would call the heyday of the large clinical trial. This is looking, for example, at the GC experience, where when one is thinking about a common disease like myocardial infarction, large clinical trials are needed to detect what would be considered a modest benefit, but an important benefit. And so GC led to the ISIS studies, which led to the Gusto studies. And it was really this recognition that we should be testing common diseases or we should be testing therapies in common diseases in large sample sizes, the so-called large sample trial or the so-called mega trial, to really understand what is the treatment effect, what is the aggregate of all the good things that happen to patients balanced against the bad things that happen in that particular application of therapy. Go to the next slide. Here was the steering committee from the Gusto trial. And some of you will remember this, but some of you were not certainly around 30 years ago when we did the Gusto trial. I was a fellow during Gusto. I was actually one of the on-call physicians who answered the hotline calls throughout the 3.5, 4 years the Gusto was going on. This was the steering committee. A couple of things you note. One of which is that there are only men in this picture. And I think that reflected cardiology largely at the time, but it's not the kind of picture that we would have today of one of our large steering committees. Secondly, this was an effort that took place around the globe, and you'll recognize a lot of the people in the slides here, people from Belgium and Australia and Spain, people from the Netherlands, people from France, Canada, Poland. So there were people from around the globe that really needed to come together. So big teams representing diverse perspectives from around the globe, best suited to answer these questions. Next slide. And it was at this time then that there was a prevailing notion that we were only going to be able to answer questions that largely were going to result in modest to moderate sized treatment effect if we had large scale randomized evidence. And so you began to see papers like this. This is from the ISIS group pointing out that there's no alternative to the generation of large scale randomized evidence. So we needed big trials. And this was the next lesson that I learned, that in order to detect these modest treatment effects that were important given the scale of the disease, you needed large-scale evidence. Next slide. Many of you will also recall that our armamentarium for the treatment of things like unstable angina and what was called at the time non-Q wave myocardial infarction was very limited. In the early 1990s, we had aspirin and we had heparin. And here was from the guidelines about how we used aspirin and heparin. We weren't sure of the dose, so the guidelines said 160 to 324 milligrams. And heparin, we actually used at fairly high doses. This was what was available to us in the early 1990s. Next slide. Many of you know that I've spent a great deal of time trying to understand the role of antiplatelet therapies. Here's a great paper by Deepak Bhatt, which really summarized around the 2014 period, all 2014, all of the different types of approaches to antiplatelet therapy. Go to the next slide. And a lot of what I spent my time on through the 1990s and the early 2000s were trying to understand the role of platelet inhibitors in acute cardiovascular syndromes, whether it was in the cath lab with the 2B3 inhibitors or it was in the setting of non-ST elevation acute coronary disease with the 2B3 inhibitors. But what you can see here is that over a period of about 12 years, a lot of work was done with the 2B3 inhibitors to try to understand their role. And it took large trials to try to look at their role in the PCI setting, both before stenting and after stenting, as well as in the ACS setting, whether you had ST segment elevation or not. Next slide. Here I had the opportunity to present the eptifibatide results of the Pursuit study in the mid-1990s. Go to the next slide. And along this way, I learned an important lesson. I learned the lesson that what we really needed to understand, if we wanted to make improvements in human health, we needed to really understand true clinical outcomes. And that intermediate outcomes were going to be insufficient. And why is that? If one thinks about surrogate endpoints, the definition of a surrogate endpoint is that it's in the true causal pathway between the disease and the clinical outcome, and that all of the information around therapy is contained in the effect of that therapy on the surrogate. In fact, that's the assumption, but that assumption actually holds true very, very few times. Go to the next slide. The example would be the suppression of PVCs, which was the intermediate outcome, and how it affected the clinical outcome, in this case, death. And that's because the disease might go to the true clinical outcome in a way other than the surrogate endpoint. And it may be that the intervention only affects one pathway and doesn't affect the other. And so you had to start to think about how then do you do trials if what you always are requiring are these large sample sizes. Go to the next slide. And so many of us began to think that there were these truisms in clinical trials. Treatment effects usually modest, qualitative interactions usually uncommon, meaning that things usually biologically are going in the same direction, but there may be bigger effects in sicker patients. But let's not forget that unintended targets were common, that long-term versus short-term effects may differ, combinations are unpredictable, and that class effects may not be valid. And these are all some of the lessons that we began to think about through the 1990s and early 2000s as we thought about the lessons from clinical trials and as the basic principles in evaluating therapy. Next slide. So how did we put this all together when I was at Duke and at the Duke Clinical Research Institute? This, I think, is a slide that I pay attention to a lot. Lessons from what's a quality clinical trial. There's not 100 things that you need to adhere to. There's only about 8 to 12, and here I've listed 10 of them. Relevant question, protocol clear, adequate number of events, reasonably complete follow-up, plan for ongoing measurement, safeguards against bias in determining clinically relevant outcome, and all done on the background of the protection of rights of research subjects. So there's not a lot that you have to pay attention to, but this is really hard to do despite these being the lessons. Next slide. I also learned a lot, and I made reference to this on my disclosure slide, the paradigm for collaboration. And while I work with industry extensively, I work with industry in a forum by which there's a lot of independence for the academics. Because while our interests may overlap, with private industry. They should never be superimposed. Our interest as academics, as clinicians, may overlap with the industry. We want to see successful products. They want to see successful products. But there's a lot of other things where our interests don't overlap. And therefore, I have found that the true paradigm for collaboration allows for much independence of the academic investigators. And that largely has to do with access to the data. Next slide. Now, this all sounds great, the lessons learned over a period of 20 plus years at Duke, but this was also a problem that we began to see emerging as we did more and more of these large trials. The large randomized double-blind trial conducted over 10 years, unfortunately, we've forgotten why, because it's gotten not to be a large simple trial, but a large complicated trial. Next slide. And as I said, I'll pick on my own work. This is the Improve It trial with ezetimibe. This was a period of time where ezetimibe was known to be a drug that lowered LDL a modest amount. But what wasn't clear was whether or not that modest amount of LDL lowering actually contributed to improved clinical outcomes. Pretty simple hypothesis. Add ezetimibe onto standard therapy after acute coronary syndrome, and did it improve clinical outcome? It took us 10 years to answer this question. And it took us an enormous amount of resource expenditure, an enormous amount of effort around the globe. And it really began to ask our questions is this really what we needed? I mean, weren't there going to be simpler ways to answer these simple questions? Go to the next slide. And so with that, a number of us were taking a step back to say, is the large trial model really the best model? Is it the large trial model that's an issue, or is it the methodologies by which we're doing large trials? And Elliot Antman and I wrote about this about a decade ago, where we said, as large trials become popular, the simplicity is lost. Might there be a way to do this better, like to embed randomization into the EMR, or to embed randomization into registries sponsored by the societies like the ACC and the HA? New slide, next slide. And around this time, then, I moved to Stanford in 2012, and really moved to Stanford with this notion of how could we do research differently? Next slide. And when I moved to Stanford, one of the reasons I did it was to think about what were the advantages that Stanford had, maybe more than any place else in the country. Stanford had little history of doing clinical investigation, but a great history of basic investigation, a great history of statistics, computer science, engineering, math, all of the basic tools that one was going to need to really think about a future where data was the centerpiece of everything. There were the possibilities of using technology in improved ways to do better trials. Next slide. And so as I began to move west, I thought about the richness of Silicon Valley from a data perspective and a technology perspective, and how might we tap into those two things as a way to have the next wave of clinical investigation, building on the lessons of the first wave to do things, including the large trial, in more effective ways. Next slide. And you know things are important when it appears on the cover of The Economist. And around that time, there was a special edition of The Economist that talked about the data deluge and the fact that in the years ahead, data would become the world's most valuable resource. Next slide. And so I was also highly informed by this book from Eric Topol, The Patient Will See You Now, which really flipped the way that we began to think about medicine, the way that we began to think about new ways of collecting data in order to inform how we take care of patients, which was Eric's book, but also the way that we might think about doing science. Next slide. And so we began with our Duke friends, with our friends from other academic medical centers, to think about how do we use some of this technology to generate better evidence and deliver better care. Next slide. And so I began to collaborate with a number of people at Stanford and elsewhere, including the technology companies. This is an example of a project led by you and Ashley of how do you use things like the smartphone to collect data. And in this project, we had over 50,000 individuals give us permission to use their smartphone as an ambient data collection tool after they provided us consent, after they provided us some baseline demographics. We could actually use this at scale to provide a lot of information about lifestyle, about activity. And we began to think, could we also use that as a way to be not just a passive data collection tool, but actually to be a little more active, including in things like clinical trials. Next slide. So one of the most important projects that our group was involved with at Stanford was the Apple Watch project, to try to understand, could we at really large scale get people to give us consent to collect their data, to be able to understand, in this case, a common health condition of atrial fibrillation. Did it appear, could we collect that information at scale, and would it be reliable? Next slide. Well, this was a remarkable project because over the course of less than a year, we had over 400,000 individuals in all 50 states give us permission to use their watch to collect data as to their risk of atrial fibrillation. We talk about, people say, well, you know, the incidence of atrial fibrillation here in an asymptomatic or previously undiagnosed population might be pretty low. And that's true. But to me, the more important message here is that we could actually collect health relevant information at massive scale in a short period of time. Next slide. So here we have our ability to show that we could collect actually data from a very diverse group of people, not just people who were healthy, but people who had risk factors. They had hypertension, they had diabetes, they'd had a previous stroke. This allowed us to really show, in fact, people were interested in participating in research like this. Next slide. And we began to integrate that information with what we were learning in our own healthcare system. And we published this paper with two informaticians about 10 years ago that also started asking ourselves the question that Stead had asked years ago: could we collect aggregated data on all of our patients and provide real-time feedback to clinicians who had questions about their patients? This would be the updated version of the Duke Data Bank, but at scale and immediate. Next slide. And so we did this. We created within the Stanford EMR environment a program that allowed us to have clinicians ask for informatics consults at the point of care and provide back to them aggregated data about their patients and patients like the patients that they were seeing. Next slide. We then said, okay, we can collect data in the EMR. We can collect data using a smartwatch. Can we do even more? Can we combine imaging data with physiologic data, with clinical data, with therapeutic data? And we entered into a project with Duke, Stanford, and Google Life Science, which became Verily, called the Baseline Project. Next slide. And this allowed us to really think about collecting at scale a lot of disparate types of data: molecular data, imaging data, self-reported data, sensor data. And could we collect all of this in a way that we could then analyze it and gain insights into human health? Next slide. So we became, at Stanford, really interested in this notion of using all sorts of new technologies to bring data together to inform the research that we wanted to do, and to begin to ask ourselves, could we do this not just in observational ways, but could we also do it at scale to answer clinical randomized questions? In partnership with ACC, we did this. Sunil Rao led a nice project to use the NCDR to do a randomized trial. And then the group at Duke used relationships with the AHA and get the guidelines in this massive data structure to begin to do randomized trials including in atrial fibrillation and antiarrhythmic therapy in a trial called Change AF. Next slide. And we did this because we fundamentally remained convinced that while clinical observation set the stage for the hypothesis for clinical research, for clinical trials, it just wasn't enough to have the observation. You still needed randomization because that earlier lesson from CAST remained true. And we have in this paper that we published a couple of years ago, there's dozens of examples of where our intuition about something, our understanding of the biology that we thought led us to the outcome was incomplete. And we learned that when we did the randomized trials. Next slide. This became never more apparent than during COVID. And during COVID, all sorts of groups were desperately trying to figure out, as you all know, what was the way that we could best treat patients who were infected and who were sick in the ICU, on ventilators, or on the verge of ventilation, patients that had multisystem organ disorders. And the Mayo Group published this paper of convalescent plasma in 20,000 hospitalized patients that really was making the case that convalescent plasma actually might improve outcomes. 20,000 subjects treated this way, but without knowledge of whether or not it might actually work. When we finally did the randomized trial of a much, much smaller group of patients, we actually learned that convalescent plasma didn't improve clinical outcomes. And so it, again, reinforced this notion that, yes, we can collect a lot of data. Yes, we can publish data on our observational outcomes. But if you really want to know if the treatment's making a difference, there's absolutely no question that you need randomization. Next slide. We then began to continue to write about this, partnering with people like Rob Califf at the FDA and various leaders of the Duke Clinical Research Institute, and trying to take those 10 lessons that we had pointed to earlier as we began to accumulate information at Duke and put forward notions of what do we really need? We need to strip down these big trials to really get at the essence of the simplicity of data collection, use new technologies, use new ways of getting at the data to really inform how we might do these clinical trials. Next slide. And so we came back to this over and over, the 10 things that we had learned in the 90s and early 2000s, and really tried to put forward in a framework for the new ways that we were doing trials, including using technology, including using digital tools. Next slide. And maybe this came to fruition most recently in a trial that we actually had tried to do almost 20 years ago, but didn't actually have the structure to do it until more recently. And this was a trial on aspirin dosing that was supported by PCORI. We had proposed doing this almost 20 years before to NHLBI, and we proposed doing it over the internet in a way that would minimize direct patient contact with the investigators, et cetera. And when we got our scores back for this grant application, the NHLBI said, this is a great idea, uses new technology, somebody ought to do it. If anybody can pull it off, we think it's this group. We don't think it can be done. That then went on the shelf for more than a decade until PCORI began to put together EMR cohorts from around the country through something called PCORnet and created common data models that could be used across multiple sites. And they wanted to see if we could answer randomized clinical trials on this backbone. Next slide. So we did it. And we did a trial that was very different than the traditional trial. We used the EMR. It was very much patient-focused. It was very much collecting data in a way that would be least disruptive to patients. Go to the next slide. And we did this study of 15,000 or so patients with only 40 sites. If you go back to the Gusto trial of 42,000 patients, we did it around the world. We had hundreds to thousands of sites. And now we're doing a trial only about a third of the size, but with only 42 sites in the United States. Next slide. And walk me through this. Keep pushing it because it's going to get, yeah, keep going. Keep going. Perfect. And what we had to do was we approached a lot of patients to the studies to join the study. About 30,000 actually visited the study portal when invited. And I think impressively, about half those patients decided to enroll and to allow us to randomize them to aspirin dosing. And the quality of the study was good. Very few withdrew consent. Very few had limited participation. This was all being done through the EMR around only 42 centers in the United States. Next slide. Next slide. Keep going. And what you could see is that these patients actually looked like typical coronary patients. A lot of prior revascularization, a lot of risk factors. All of this was taken directly out of the EMR. Next slide. Next slide. Now we're entering, during my time at Stanford, even a new world. We're realizing technology is important. We're realizing that getting more data is important. Now we're trying to figure out how do we use truly new tools of things like artificial intelligence and machine learning? Because in the area of maybe 5, 6 years ago, this really starts to become possible. And you start hearing people talk about not biostatistics or informatics, but this notion of data science and this notion of being able to bring large amounts of really disparate data together. And why were we able to do that? Fundamentally, what we're doing today with data science, artificial intelligence, machine learning was all enabled by cloud computing. That's what really was the game changer here that allowed us to think perhaps differently about how we're going to do things. Next slide. So I got really excited about this at Stanford. We recognized the challenges here. This was from a conference that we put on at Stanford, sponsored by the National Academy of Medicine, National Artificial Intelligence and Healthcare, raising both the hope, but also the perils, the challenges of doing all of this. But the world was moving this way quickly. Every time you pick up a paper, you see things like this one, computational models in cardiology. Next slide. You start to see the possibilities, though, of ways that we could do research using things like ambient listening devices, like the Google Home device or the Amazon Echo, that you could actually start to imagine, can you collect data at massive scale using some of these ambient listening devices? Could you imagine doing quality of life questionnaires, not on a Q6 month basis, but daily? Because Alexa can ask you the question, hey, Bob, how are you feeling today? Can you answer a set of questions for me? So you're now entering an era where technology, the ability to accumulate large amounts of data is really going to change the game. Next slide. You can see that when you do things like ask Alexa to teach you CPR. Next slide. But you can also see some of the perils in it, as some of the work we've seen with generative AI and ChatGPT, hallucination, making up data that appears real. And so we're entering this era where we have amazing technology, amazing abilities to collect data, but also some cautionary notes about how we might want to be careful. Next slide. We wrote a paper about this a couple of years ago with Nigam Shah, an informatician, Abraham Verghese, a physician author who many of you know. And we built upon Dr. Stead's comment of what this patient needs is a doctor. And we called the editorial, what this computer needs is a doctor. And how do we bring together the human elements and the issues of artificial intelligence? And we wrote it as a sort of a piece on humanism in medicine, but really this also applies to clinical research and clinical trials. How do we combine the best that we're finding in technology, data collection, artificial intelligence, but with the human elements of being a clinician investigator? Next slide. Because maybe we're not too far away from this. Our statistician will drop in and explain why you have nothing to worry about. Because now we're really seeing this convergence of data in biology, where we really need, as clinicians, to be able to understand the data issues in order to take better care of our patients. Next slide. And we talked about this a lot at Stanford. In fact, this was our 2020 annual report, the rise of the data-driven physician. How were we going to give skills to the next generation to be able to deal with all of these issues? Next slide. And then as I was in the midst of doing all of these really exciting things at Stanford, after 11 years, I hadn't been looking for a job, but a job seemed to find me. And I was very excited and remain very excited to come back east to Weill Cornell. Next slide. And I'm beginning to think about all of the lessons I've learned over the last 30 years and how do we apply those in the next iteration of doing cardiovascular research, of doing clinical trials for populations at scale. This was a paper written in collaboration amongst the AHA, the ACC, the European Society of Cardiology, and the World Heart Federation. Next slide. And I begin to think about how trials can best be done. And it's really just building upon those 10 elements that we talked about, that we learned through the 90s and the early 2000s, and that continues to be the basis of what we need to do. Next slide. But we now have new technologies. We have new ways of collecting data. We're able to do things now at scale that we weren't able to do before. I'm the study chair for this program with a factor 11 inhibitor that's doing 3 very large trials simultaneously at scale, enrolling tens of thousands of patients, collecting data in a common platform, defining things in common ways, having a single DSMB that's able to look across all of this data across different trials. All of this enabled by technology and the lessons of the last 30 years. Next slide. But one of the things we got to get back to doing, which was one of the key issues that the GC group really pioneered in the 1980s, we got to get things at the point of care that are simple and practical. Thank goodness the UK had the structure and the people to help lead us on this during the early days of COVID, where they began realizing right away you had to make trials simple at the point of care so that you could actually learn if simple therapies like steroids in hospitalized COVID patients might be valuable. And so those early lessons are coming back, that even though we have some amazing technology to be able to understand how to do things, we really also need to take a step back and say, how can we do them more simply? Next slide. And this is something that I'm going to spend a lot of time on in the next phase of my career, is how do we better integrate research into practice, something that Stead wanted us to do 50 years ago. We now have the technology tools, we have the data collection instruments. How do we better integrate practice and research? Next slide. Some people are doing it. This is just an example at Vanderbilt where they're doing trials in their own healthcare system at scale, answering just some simple questions. Next slide. And so you'll hear me talking about how we're going to do this and how we're going to use data for things like adaptive trials. We can repeatedly test things, adapting the population, adapting the therapies as we go along. Next slide. And here was a great paper from the Yale group that appeared just a couple of months ago that's now talking about the next phase of adaptive trials using artificial intelligence and using things like adaptation based on the patient populations that seem to be most likely benefiting from a therapy as the randomized trial is going on. So how do we do all of these things and come up with better evidence to take care of our patients? Next slide. So that's what I've learned over the last 30 years. I've learned that clinical practice and clinical research can be and should be better integrated. I've learned that you need to have teams with diverse expertise to come up with the best answers. I've definitely learned that while clinical observations can be the basis of hypotheses, our intuition is often wrong and we need randomization to test it. Randomized trials need to be simplified, but you got to pay attention to the essentials. We need diverse funding mechanisms, and we have great opportunities right now with new technologies, massive amounts of data, computational tools like machine learning and artificial intelligence, but we need to study it along the way. Next slide. So thank you for having me tonight. I'm happy to answer questions in the last 10 minutes or so. I love this slide. When you two have finished arguing your opinions, I actually have not just data, but randomized data. So thank you very much. And thank you for Dimitri inviting me to this. And I look forward to the questions. And maybe they'll take down the slides. Yeah, thank you.
This was, thank you so much, Dr. Harrington. Truly amazing summary of the last 30 years of research and clinical trials. And there's a couple of questions that have come online during your talk. Let me start with the first question. In your opinion, what is the clinical research going to look like in the future? So someone asked in 2054, what is what are clinical trials? Are they going to look like embedded randomization in EMR, like the adaptable trial? Are they going to look like embedded randomization in registries like NCDR? What do you think is going to happen?
Boy, I would like all of that to be the case. I fundamentally believe, Dimitri, that clinical people only make or should only be making two types of decisions when it comes to when it comes to clinical decision making. You either know the answer, in which case the system should help enforce the answer. The example I always give is aspirin in acute ST elevation myocardial infarction. That's only about 20 to 25% of what we do in cardiology. The rest is the vast morass that is clinical practice. I think that we don't do enough of embedding randomization at the point of care to answer the questions. I think that we should be revisiting, for example, informed consent for every single thing. I think we should be thinking about different types of clinical trial designs. If you went to see your primary care doctor and you had bronchitis and there's several options for therapy, why not randomize you? Always try to find the answer. So I would like to see it be a more actively ongoing process that's behind the scenes. You know that if you go to Google search right now, you're in 6 randomized experiments on average, because they're looking at all sorts of things. Where do your eyes go? What colors do you seem to like? And they're constantly doing that. And in the tech world, that's called A/B testing. We don't do that in medicine, but why can't we? So I think there's going to be more of that. The second thing I think is that we're going to get much more sophisticated about doing things at scale because we can, and we're going to be able to collect massive amounts of information and move that along much more quickly. I think that adaptable was a great experience. There's still a lot of challenges with it. If Sunil Rao was on, he did one of the first trials of embedding called Safe PCI. Randomization into the NCDR, and you can ask Sunil. It sounded like a great idea when we pitched it. It had a lot of challenges to it. But I think we're going to get better at that stuff and use the NCDR. You know, our Swedish friends do this constantly in their Swedish registries.
We have a question for you from Dr. Bott, and you've mentioned his slides and collaboration with him. Any thoughts on the synthetic data in similar proposed trial innovations?
Oh, yeah, I think that's a great question, Deepak. I think we're going to see a lot of work in clinical trial simulation. We're going to see a lot of work in the creation of synthetic data and being able to test hypotheses. I still think we're going to have to test things ultimately in the intact human being with all the foibles that humans, the world in which we exist, so-called real world. But I think Deepak is making a really important point that we're going to do things like digital twins and the creation of being able to understand how things might play out in a hypothesized way. So really important observation, Deepak, and I think we're going to be doing that.
Another great question came about AI and the role of AI in the future and how will it change the way we approach and the way we do research?
I think one of the things that we have to, as a community, understand, whether we're talking about research, education, or care delivery, AI is a tool, and it needs to be used as a tool. Radiologist who I became great friends with at Stanford by the name of Kurt Langlotz, he would always be asked, will AI replace radiologists? And he says, no, but radiologists who use AI will replace radiologists who don't. And I think the same could be said about cardiologists. Echocardiographers who use AI will replace echocardiographers who don't, because it's a better way to read the echo, more efficient, more reliable. Clinical trials are being, David Wang from Cedars-Sinai has shown us that in clinical trials, the machine's better at reading things like EF than some of us are. So I think that AI is going to change it a lot. We're going to have to use it as a tool. But here's what I would say is that we should expose it to the same rigors of randomization that we expose any tool to. And that we should try to, and David's been doing a great job with that at Cedars. He's been able to really randomize people who, or randomize the exploration of a tool versus the way we usually do things. I think it's just going to keep getting more and more sophisticated. I was fascinated by that paper coming out of Yale about how and Deepak has written a lot, for example, about adaptive trial designs. This is using AI to do adaptation along the way. Raises a ton of questions. Preservation of the type 1 error is one question, but there's a lot we need to think about. We should test it.
Now, you've during your talk, you've made a terrific point about the surrogate endpoints and how they may frequently be insufficient, and we really should be looking at true clinical outcomes. But sometimes in clinical practice and trials, it is quite difficult, and a lot of the devices that have been studied, approved, left atrial appendage devices, renal denervation devices, are really approved and studied with surrogate endpoints. So where do you think that field needs to go? Do we need to sort of embed and look at outcomes once the approval has been to make sure that we didn't miss the true clinical outcomes, or should we be incorporating those early on in the design of the clinical trials?
It's a great question, Dimitri. I would say, and there's a question in the chat about this as well, that I'll try to tie it together. The question has to do with causal inference and observational data. I was recently invited to a meeting of some of the experts in causal inference and observational data, and I considered myself the sacrificial trialist at their meeting because my basic point was you can't adequately draw causal inference from non-randomized data despite all the fancy math. Now, having said that, I do realize that that some questions are just going to be impossible to answer with randomization, and that one needs to try to understand a technology like a device as best we can. But I don't want that to be the default. And I worry a lot, Dimitri, that we default to using observational data. And I'll give you one of the examples that's talked about a lot in in interventional cardiology: mechanical support in acute myocardial infarction. I keep being told, well, there's no possible way we could study that in a randomized way. Well, why not? I mean, for me, it's more, let's spend the energy figuring out how we should do it instead of defaulting to observational, non-randomized conclusions. And mechanical support's a great example. I mean, you can show me as many papers where it looks to be beneficial as there are papers where it looks to be harmful. And so to me, that's the best time to do a randomized trial because there's equipoise. And we should be thinking about it that way. The surrogate question, I would actually say, first, let's use the right terminology. Most things aren't surrogates. They're intermediate outcomes. They don't meet the criteria to be called a surrogate. LDL lowering with about 5 classes of drugs is a surrogate. There's a pretty good relationship between lowering LDL and clinical outcomes, and it's highly predictable that the effect on LDL, like the 10-15% reduction in LDL lowering with ezetimibe, would be predicted to give you an 8 to 10% reduction in clinical outcomes. And in fact, that's what the clinical trial showed, improve it. Same thing with PCSK9, same thing with bempedoic acid. So I do think that there's a role for the intermediate outcome. I do think definitely there's a role for the intermediate outcome early in development, but I think there's still work to do with those.
This is terrific. I know we're running short on time. I'll open it to my co-moderators and perhaps last question. You've done a lot of work with the FDA, with the advisory committee for the cardiovascular and renal drugs. And there's been a lot of conversations about the sort of the US approval process versus European. Some think it's too thorough, others think it's not thorough enough. Having been so closely and hands-on involved in the process, can you give us your sort of opinion about the process and what needs to be better or what could be better?
I've spent a lot of time over the years working on behalf of the FDA and working on behalf of industry sponsors. So I've seen both perspectives. I would say I've never come away from a meeting with FDA where I haven't been enormously impressed by the quality of the people doing the work who are looking after our public health. And many of them could be doing many other things, but this is what they choose to do because they want to protect the public health. I still think for all its problems, we still have the gold standard for regulatory oversight of medical therapeutics. It has challenges for sure. I've argued with them, and many of you have been there with me arguing. Deepak is a good example when I think that they've just gotten it wrong. But they get it wrong with a reason, and they're usually willing to entertain an alternative reasoning if you can make your case. I've never learned so much as when I served on the cardiorenal advisory panel, to see a notebook prepared by sponsor and a notebook prepared by FDA on the same set of data that looks like totally different things is a remarkable exercise. And if you're interested in clinical research and clinical trials and you have an opportunity to spend time at the FDA, you should absolutely do it. Highly recommended. I think we have lessons I think there are things in Europe that they do better than us on the device front, for example, that we could learn from. But I do think the US largely has the best regulatory oversight. Very biased. People also know that, my primary mentor is Rob Califf. He's the FDA commissioner now. And so I do think it's a great organization.
Well, let me just, on behalf of myself, my co-moderators, and on behalf of New York State ACC, thank you, Dr. Harrington, for joining us for this amazing, truly amazing summary of clinical trials in the last 30 years and webinar. Any last closing remarks that you want the participant take away?
Yeah, all of you have been listening. If you're not involved with the research process, get involved. We need your help. We need. Somebody asked a question about globalization. One of the reasons we do it around the globe is because the disease is around the globe. But one of the reasons we do it around the globe is because we can't just do them in the US. And that's because many of us and many of our institutions don't actually participate in research. Part of what I'm going to spend my time on in the next decade is trying to make research easier and easier so that more people can participate. So that would be my plea, Dimitri. Get involved.
Absolutely. Thank you so much. Thank you so much for joining us, and thank you to all of you for joining this evening webinar.
Thanks for having me.
Absolutely. Have a good night.
Bye-bye.